So welcome everybody to, is it number 9 now? Or the 9th rounds that we have. And today, again, we're very happy to have Dr. Esteban Santiago, who is in Buenos Aires. And he has already spoken to us before, and we love that talk. And now we hope to look and learn more from this upcoming talk on some of the advanced uses of excimer lasers. And Esteban is working pretty hard in Buenos Aires, working with pediatric population, adult population involved in refractive surgery and cornea surgery. And so, Esteban, thank you so much for taking the time to be with us today and for sharing your cases with us today.
You're welcome. Thank you very much for the invitation. Good afternoon, everybody. So I will share my screen. And
while you're setting up, if I could ask whoever is on to mute their mics so we don't get any feedback or extra noises, that'd be great. Thank you.
Okay. So I will go ahead and start the presentation. So I will share 2 cases today that I had in my private practice, and the idea is to share my thinking process for these 2 cases and the execution I did. I think this is going to be interesting for residents or fellows that are going to encounter cases like this. And we're going to stop between cases so we can discuss with others what others would have done for cases like this. So I'm going to go ahead and start with case number 1. Okay. This is a 78-year-old man that is a farmer, and he was referred to me for a pterygium surgery, and he was complaining at that moment of a decrease in visual acuity in his right eye, affected eye, for a few months. He has a past ocular history of a cataract excision with IOL implantation in the back, in both eyes 2 years back, and his best corrected visual acuity at the moment of the consultation was 2100 and 2040 with a pinhole in his right eye. His left eye was 2020 with his correction. At the slit lamp, we could see this severe pterygium affecting the visual axis, and other less significant findings were some signs of ocular rosacea that I didn't think at that moment that were severe enough to be treated. So I planned to do a pterygium excision with a conjunctival autograft. And 1 month after the surgery, he was doing well. He recovered a 20/30 visual acuity, even though he had this scar approaching the visual axis. But he was happy with this, and he didn't want to pursue any further treatment at that moment. Because he was a farmer and he lived far away, I only saw him for the first month, and he went back to his town. But he came back 8 months later, complaining of a decrease in visual acuity in the affected eye, the right eye, that was 2100 at this moment again. At the slit lamp, we could see this central band-like subepithelial fibrosis that went from limbus to limbus and was affecting the visual axis. I did an OCT, and here we can see the subepithelial fibrosis, and we can see all the irregularity that it is producing. It has some different thicknesses, producing peaks and valleys, and we can see that the valleys are filled up with epithelium. The epithelium usually does that to try to compensate for all the irregularities. And all these irregularities are what are producing all the irregular astigmatism that is decreasing the visual acuity and visual quality of this patient. We can see that the thickest area of the fibrosis is 130 microns, and the thinnest area is 10 microns. And this is some important information that we should take in consideration when we're going to decide about a procedure to fix this. What options do we contemplate for this patient? So my first option for him would have been to do a contact lens fitting that we know that they do a very good job replacing the corneal surface and improving the irregular astigmatism. Like in these two patients, for example, these are two pediatric patients. The one in your left is a post-adenovirus corneal scar, and the one in your right is a post-traumatic corneal flap. And both of them are seen 20/20 with a contact lens. But this patient, because he's a senior patient that didn't want to use a contact lens, and because he's a farmer, so his work environment maybe wasn't the best for a contact lens user. So this wasn't an option for him. We could do a keratoplasty also, but this is I think that this is a more invasive option, and that should be reserved in case that less invasive options don't work. So we're left with the PTK that I think is a great option actually for him. It has shown very good results for cases like this, and it is less invasive, it has a fast recovery and less demanding follow-ups also. We usually consider doing a PTK when we want to treat pathologies in the anterior 1/3 of the cornea that are affecting the visual axis, even though it has been reported by this Japanese group that doing PTK in mid-stromal corneal scars can actually improve visual acuity, visual quality, comfort in film, and epithelium quality. At least at the beginning, when we are learning these techniques, we should avoid actually doing PTK in very thin corneas or very irregular corneas with very thin areas to try to avoid perforation. The patient and the surgeon should understand that the end point of this procedure is not to remove the entire corneal scar. The end point is to reduce the scar density and to create a more even corneal surface. So we're trying to avoid a more invasive surgery, and a second intervention might be needed. Mainly because there might be changes in uncorrected and best corrected visual acuity due to myopic or hyperopic shifts, depending on the area of the cornea that we are ablating, and we can also induce or modify the astigmatism that the cornea has. The patient might need to wear glasses after the surgery, even if he didn't used to wear glasses before. There might be recurrences of the fibrosis. The patient might need some further treatment, and there are always risks of infections, haze, and melting. So because this patient had this mild rosacea that I think that together with the unfriendly environment where he works, were the cause of the fibrosis, I decided to treat him with doxycycline 100 milligrams a day for 1 month, Restasis twice a day, and non-preserved lubrication, and we planned to do the PTK 2 months after. There are different techniques that we could evaluate to do the PTK. We could do a PTK after mechanical epithelial removal. We can do PTK or a transepithelial PTK with a masking agent. We can combine the PTK with a refractive treatment or with a treatment to avoid a hyperopic shift, like a mid-periphery laser keratectomy, for example. Or we can use some of the newer topo-guided PTKs or wavefront-guided PTK. My first option here would have been to do a topo-guided PTK that has shown very good results treating corneas like this and improving the irregularity in the corneal surface. Lately, we have seen also some good results using the latest devices for wavefront-guided. But I didn't have any of these two technologies available, so I had to go with a conventional treatment. So I decided to do a transepithelial PTK with a masking agent and mitomycin C. Why did I choose a transepithelial PTK with a masking agent instead of doing a mechanical epithelial removal or a transepithelial PTK alone? So as we saw before, this fibrosis is producing all this irregularity in the cornea. And we saw that it is producing some peaks, and the epithelium is filling up the fibrosis. So we want the epithelium to work as a masking agent. So when we are ablating the peaks of the fibrosis, we will be ablating, at the same time, we will be ablating over the epithelium. And for the same reason, we're using the masking agent. At the moment when we are ablating the peaks of the fibrosis, we will be ablating over the masking agent. And why didn't I combine the treatment with a refractive treatment? Mainly, the reason for this was that the ablation rate for the excimer lasers is different for the fibrotic tissue and for the normal tissue. It's not the same ablation rate. And it is even different in different areas within the fibrosis, different areas with different densities. So at the end, we don't really know what the refraction defect is gonna be after the treatment. So I prefer to do it simpler, and I offer the patient to do the PTK. I use a large ablation zone and a transition zone to try to minimize the hyperopic shift. And 3 months after, if it is needed, I would treat with a PRK the refractive defect that we have created or unmasked. It is usually recommended not to go deeper than 100 microns during the first treatment to try to avoid the refractive changes the most we can. For the same reason, the idea is not to ablate the entire fibrotic area, but to create a more regular cornea to decrease the irregular astigmatism. So I did transepithelial PTK with a masking agent, and I used mitomycin C at the end. I did a central 100 microns ablation using an ablation zone of 6.6 millimeters. I paused the laser a little bit after the half of the treatment when I saw that the epithelium was all removed, and it was there when I used 2 drops of the masking agent I was using. And then I continued the ablation until the end. The bottom OCT is the 3 months post-op OCT. We can see there how the fibrosis is almost all gone. We can see a very, very thin area of fibrosis that is still there. And we can appreciate actually how the cornea looks much more regular than it used to look before. We can see here how the cornea is looking much more clear, and he improved 3 months after to a 20/30 best corrected visual acuity. If we pay attention here to the post-op manifest refraction and the pre-op manifest refraction, we can see that there wasn't much of a hyperopic shift there. But if we compare the post-op manifest refraction with the pre-scarring manifest refraction, we can see that we have actually induced a 1 diopter hyperopic shift and some astigmatism. So it is at this moment when I did offer actually to this patient to do a PRK, and he was happy actually with the result. He didn't want to pursue any further treatment. So I didn't operate again on this patient, at least up to now. But that's an option. So this is the end of case number 1. I don't know if somebody wants to share their experience with cases like this, or I'm actually interested in seeing what others would have done for this case.
All right, thank you. Any comments from the audience? While they're thinking, Esteban, I had a question. Can you tell us and the other attendees, when you're doing your ablation, when you stopped halfway through, what were you looking at to see that this was epithelium that was being lasered versus stroma being lasered? How does it look different?
Yeah, so whenever you're ablating over the epithelium, it makes, if you have a dark room, it's always good to do it under a dark room, so you can see like a blue color when you are ablating over the epithelium. It's like a bluish color. And if you are ablating over the scar and over the stroma, it is like a darker thing, as well as the sound of it. It is more like a semiology thing. When you are ablating over the epithelium, it's more like a sharp noise. And it is different when you are ablating over the stroma and over the scar. It's not as sharp as with the epithelium is. Okay. So whenever I see those changes, I just change to the, I just put my masking agent.
So when you're doing that and then you see a homogeneous color, is that where you stop? Or do you ride through the entire 100 microns?
I actually go until the end. I just planned. I do everything that I have planned. There are some surgeons that like to take the patient to slit lamp to see if the fibrosis is already gone, to see if they have to continue with the PTK. But I like to do the whole treatment. I measure everything with an OCT before. And I know that the worst case would be for me to do less ablation that I have planned, because I am using actually the masking agent that will avoid some areas of ablation. So I actually go until the end. I did 100 microns.
Okay, and so can you tell us more about what the masking agent is that you use and how you use it and how long you wait for it to dry, and what do you do exactly?
Yeah, I actually used HPMC. It's an artificial tear, 0.7%. I like to use that one because it is less viscous. But if researching the literature, you can see that there have been a lot of different drops that have been used, carboxymethylcellulose and dextran and a lot of things. I actually feel comfortable using this HPMC. And what I do is I put 2 drops. I try not to overflow the eye, just 2 drops over the cornea, over the area that I'm ablating. And with a Buexal, I try to dry up it a little bit, just from the corner, to try to draw some of the liquid. Just until I see that some of the peaks are appearing over this liquid. And at that moment, I start ablating again. And I usually don't, I usually do it only once. I put the masking agent only once, because if you put it many times, you can actually induce more irregularities and more aberrations in the cornea. So I do it only once, and then I go until the end.
Okay, and if you just kind of go back to, again, some basic principles for those people in the audience who are not surgeons, why are we using a masking agent? What's the purpose of it?
So I will go back.
Go back to that drawing that you showed the arrows on, and you can maybe illustrate it a little bit more. Yeah. I just want to make sure people understand what this is. That's an important point.
Yeah. Let me move forward. Here. So we have all these fibrosis in the cornea that is producing all these irregularities. If you see here, it has different thicknesses in different areas. So we can see, as in this area, we can see some peaks, also in this other area, and we can see some valleys of fibrosis. So this darker area that I'm signing, so all that I drew there is the fibrosis, and this darker area that I'm signing is the epithelium that's filling up these deeper areas, these valleys. So as I said before, the epithelium usually does this to try to compensate for all the irregularities in the cornea. So I use this masking agent because when we are ablating with the excimer laser, I want it to ablate first over the peaks of the fibrosis, and I don't want it to ablate over the valleys, because if I let it do that, if I ablate at the same time the peaks and the valleys, it would translate the same irregularities back to the deeper tissue. So the idea is, while the excimer laser is ablating over the peaks, at the same time it will be ablating over the valleys, the epithelium that's filling up the valleys. So the epithelium is working as a masking agent. And the same reason to be used has the masking agent. So the masking agent will fill up the valleys while we still have some peaks for the fibrosis or irregularities. So while I am ablating over the peaks of the fibrosis, in this case, of all the irregularities, I would be ablating over the masking agent. And at some point, the masking agent will get evaporated, and I will start ablating over the tissue. But at that point, I'm planning to have a more regular tissue.
Right, and I think that's something that, you know, when I was learning about this, it was an aha moment when I realized, yes, you know, if you do take the epithelium off with your debridement or the alcohol, by lasering what you have left over, it's going to transmit that exact same shape, but just deeper down. And so then the epithelium, in this case, or as you mentioned, your drops can add, so you basically flood the valley and just shave off the peaks of the mountains, and eventually it gets to be a bit more of a homogeneous or kind of smoother surface. So I think that's thank you very much for this illustration here, Esteban. It helps imagine what's going on. And so what instrumentation or what devices do you think are important for people who are considering these kinds of treatments? What should they have in their devices?
So whenever we are planning this, it is good to have actually having an OCT and being able to measure the actual thickness of the fibrosis. It's something very useful, because you can perfectly plan the treatment that you're going to do. Before having these OCTs, before being able to measure this so precisely, we used to do it with the slit lamp, right? We just guessed whatever the thickness was, and we tried to aim for the perfect thickness. But at this, I think having the OCT measures is perfect for this. Another recommendation would be to carefully select what tiers are you going to use for the masking agent. You don't want it to be very viscous, because it will create some irregularities, and the treatment is not it's not going to be efficient also. And when you're doing the actual PTK, you can do, but maybe it is easier when you're going to start doing this treatment to use a spatula to pass over the cornea, just to get rid of the excess, the excess liquid over the cornea, and some liquid will stay in the valleys, so you will still ablate over the masking agent. That might be easier, at least at the beginning.
Okay. There's a question here. It reads, do you do anything differently with regards to plant ablation depth and the amount of time of intraoperative mitomycin C application and the amount of steroids that you would give if you had to repeat PTK a second time for recurrent scar, fibrosis, or nodules?
No, if I have to repeat the treatment, I would do the same. I would do I would measure it with OCT. I try to minimize the ablation the most I can to try to avoid the refractive changes the most I can, right? But I would do the same thing. I would measure it with the OCT, and then I usually use the mitomycin C, 0.04% concentration, and I usually use it for no more than 20 seconds. It is actually reported that doing it for a longer time is not actually useful. So I usually use it for between 15 to 20 seconds.
Okay. And what role, actually I'll read another question here. Have you used something called PALM gel, P-A-L-M gel, before as a masking agent? And some have reported that it might give more controlled results.
No, I haven't. No.
Yeah, I have not either.
Where is it made for?
I'm not sure. I have not used it. Apparently, it's not available where the question is coming from, Saudi Arabia, but I don't know.
So there is actually a paper wrote by Carmel and group that he reported that using dextran 0.1% might be the best for these kind of ablations due to the viscosity mainly. Okay.
And so what role do you think epithelial mapping will have with this?
I think it will work mainly if you have a topo-guided treatment, as I said before, because using a topo-guided or maybe one of the latest waveform-guided treatment, you can actually aim to treat all the irregularities and all the aberrations in the cornea. So that's a technology that's going to be useful when we can join it with that technology that I didn't have available at that moment at least.
Okay. So then, Esteban, if you were to come across a patient who, say, I don't know, 30-year-old patient who has recovered from contact lens related scar, infectious keratitis, has a scar, and you do the OCT and you realize, except for where the cornea is entirely normal, except for where the scar is, there's maybe epithelial plug of about, I don't know, like say 100 microns. So you have this little small, say 1-2 millimeter area of epithelial plug, but everything else is normal, and they say, no, I don't want to wear contacts anymore because of what happened. I want to get, say, laser vision correction. So the patient with this otherwise normal cornea, except this 100 micron plug of epi that shows a dip where the scar was, how would you go about doing laser vision correction on this patient?
Yeah, I would try to fix this irregularity first, because we have learned that doing laser vision correction in already aberrated corneas can induce actually more problems after. So I would do, if it is only epithelium, I would do a superficial keratectomy without doing a PTK. If there is a need for a PTK, I would do it before doing the laser vision correction. So I do any of those two treatments. I would wait for at least 3 months for the eye to be recovered. And after that, I would do the measures to do PRK or LASIK or whatever we're planning to do.
Okay, awesome. All right, and this is the, your OCT is the Anterion? What OCT
no,
did you use for this?
Heidelberg Engineer.
Okay, awesome. Okay, nice case, Esteban.
Thank you. So I will go ahead and start with case number 2. This is a 23-year-old male that was referred to me for refractive surgery in his right eye. He actually came as a second opinion after going to a very well-known institution here in Argentina, where he was offered an ICL implantation in his right eye. He wanted to know if there was any other option that we could contemplate. So he has a past ocular history of a PKP in his right eye when he was a child due to a trauma. And he was complaining of not tolerating glasses due to the big difference, the refractive difference between eyes, and he doesn't tolerate contact lenses either. His uncorrected visual acuity in his right eye was 2400. His best corrected visual acuity in the right eye was 2050 with a minus 9.25, minus 3 at 30 degrees. And the left eye was 2020 with a minus 1.5, minus 0.75 at 50 degrees. So we can see that he has an amblyopia in his right eye and an isometropia. At the slit lamp, we could see that he has this small 6 millimeters off-center graft. He has, his AC is deep and quiet. He has a clear lens without signs of sonular weaknesses, and the fundus exam was normal at that moment. I did the pentacam. What we see here in the pentacam is actually common to see in post-PKP patients. In the anterior elevation map, we are seeing an asymmetric irregular astigmatism. In the posterior elevation map, sorry, the anterior curvature map. In the posterior elevation map, we are seeing some abnormal elevation, but it shouldn't confuse us with a corneal ectasia. This is actually produced by the graft-host junction that's causing these abnormal elevations. He has a normal pachymetry, and I couldn't measure the aberrations in this eye, but we know these post-PKP patients have a high level of high-order aberrations. And this specific patient, because he has a small off-center graft, he will have a high level of coma especially. This is the left eye, which is a normal eye. We can see in the anterior corneal curvature, low power regular astigmatism, and posterior elevation is normal, and corneal pachymetry is normal. I did this speculum microscopy is also normal. This is good to have whenever we are planning to operate in a post-keratoplasty patient, even if we are planning to do a laser vision correction, and even if the graft is looking perfectly clear. It is always good to know that the cornea is healthy enough to go to a surgery, and from the legal standpoint of view, this is always good to have in our charts also. I did some measures, AC measures, to see if the patient was a good candidate for an ICL implantation. I used the OCT and the ORB scan to get these measures, and that he actually had all the proper measures for an ICL implantation. During his first visit, I tried to do a cycloplegic refraction, but because he had this small and off-center graft, whenever I dilated the pupil, this graft induced so many aberrations that the vision dropped to worse than 2200. So I couldn't get a good cycloplegic refraction to help me decide a surgery. So what I did was to repeat the manic refraction 2 more times in 2 different visits. And still, I couldn't get any consistent results. If we see the spheres, they are all different. The cylinder power are different, and the axes are different also. And this has to be with the high level of higher order aberrations that the high amount of higher order aberrations that these corneas has. We have actually learned that higher order aberrations can change our sphere and seal power. And they can actually do these funny things, changing the refraction between days. So what options do we contemplate in this patient knowing that he has a corneal graft this graft is small and off-center, we are going to operate in an amblyopic eye, and the fellow eye is myopic, so he's going to continue wearing glasses after the surgery. So my first option for him would have been to do a contact lens fitting, but he couldn't tolerate contact lenses, so that's not an option for him. Glasses are not an option either because of the anisometropia that he has. So we are left with two options, a fake IOL versus a laser vision correction. From the fake IOLs, I would choose an ACL because it would be implanted farther away from the endothelium. And from the laser vision correction, for these cases, I always choose to do a PRK because I don't like creating flaps in this kind of corneas. So we have to decide between an ACL and a PRK. And at that moment, I made a pros and cons list in my head to try to decide what to choose. So the pros and cons list for the PRK was this. The pros are that it is a less invasive surgery. It has a fast recovery, even though it is not as fast as the ACL recovery. The growth, especially in the endothelial cells, as much as the ACL will. And the cons is that because this is going to be a high diopter correction, there are higher chances for us to induce haze in this cornea. For the ACL, the pros are that ACL are usually highly predictable. But I don't think that this is the case for this specific patient, because remember that we have a small off-center graft with a high level of higher aberrations that the ACL is not going to correct. So I think that this is a patient that's going to be more uncomfortable after the surgery than it was before. Another pros is that it is a fast surgery and it has a faster recovery than the PRK. And the cons for the ACL are that this is an invasive surgery in a highly aberrated eye, that it will affect endothelial cells more than the PRK will. It can induce early cataract and glaucoma, and we are already operating in an eye that already has higher chances of having early cataract and glaucoma due to the chronic use of steroids. And because this is an invasive surgery, there are always risks of inducing endophthalmitis. So whenever I'm deciding between two different procedures for a patient, I always try to decide the less invasive and less risky procedure that's going to give the patient the satisfactory result that he's looking for. So in my head, the best option for him was to do a PRK. And another thing that we talked with the patient before deciding to do a PRK is that we don't really need to treat the 100% of the refractive defect in his specific case, because he's going to continue wearing glasses. The fellow eye is 1.5 diopter myopic, so it wouldn't be bad for him to be left with a 1.5 diopter to 2 diopters refractive error. Because the idea here, the surgery is aimed to improve the anisometropia and not to correct the full myopia. So that's another reason for me to choose a PRK, and treating a smaller refractive error would give him less chances of having of inducing a case also. So now that we know what procedure we're going to do, we have to decide what are we aiming it for. Remember that we have 3 different manifest refraction. We have 3 different spheres, 3 different cylinder powers, and 3 different axes. And we also have a pentacam with a different cylinder suggestion. So what do we do here? the first thing I did was to rule out the third manifest refraction because it was the one that gave me the worst best corrected visual acuity. So we're left with two manifest refraction and the pentacam. And these two manifest refraction are closer to each other. So because, as we talked before, we are planning to leave this patient 1 diopter and a half to two diopters myopic, the sphere I chose to treat a 7 diopter spheres that would give me almost close to that result. So after choosing the sphere, we have to choose the cylinder power and axis, and we have to try to be the most accurate we can when doing this, because we know that changing the axis by 1 degree will cause a loss of a 3.3% in the effect of the correction. And whenever we have a discrepancy between the manifest cylinder and the measured cylinder, we can actually induce a new cylinder in a different meridian. So we have to try to be the most accurate we can when selecting the power and axis. So we have learned from the topo-guided treatments that optimizing the axis with the topography suggested axis will give us a better outcome. So my first option here would have been to do a topo-guided treatment that we know for these highly aberrated corneas have the better result. It would have helped me to refine my result by improving the higher order and lower order aberrations at the same moment. But I didn't have that technology available, so I had to go with a conventional treatment. But I can still improve my axis by bringing it, my cylinder power and axis, by bringing it closer to the pentacam suggested power and axis. So that's what I did, and I plan to do a conventional treatment aiming for a sphere minus 7 sphere, minus 2.75 at 32 degrees. So there we have the optimized cylinder. So that's the idea, and used a large ablation zone with a transition zone to try to decrease the impact of the aberrations that we are not treating. The post 3 months, this is the 3 months post-op, he has a manifest refraction of 20/40 minus 2, which is a little bit better than it was before the surgery actually, with a minus 0.75, minus 0.75 at 120 degrees. He's actually happy with this result. He can tolerate glasses now, and he's actually happy. If we see at this result, we can see that the sphere is actually more closer to plano than we aim it for. And this has also to be with the higher order aberrations. So I think that it can be a good advice that whenever we are doing a conventional treatment in these highly aberrated corneas, it is better, I think, to leave the patient a little bit undercorrected, because we can have these changes after the surgery. And it's good to leave more room in the cornea in case that we want to do a second treatment after. Okay, so this is the end of case number 2. I would like to know what others would have done for this case.
Okay, thanks, Esteban. Any comments from people in the audience? Yeah, these are interesting cases. I think you asked what I would have done. I think I would have done what you would have done. What you did actually was first try the contact lens. That's kind of like the one that would kind of give us a nice conservative approach, but at the same time achieve the vision goals that we want, and not putting the graft at risk. I just had a question. How old was the patient, Esteban? I didn't catch that at the beginning.
Yeah, he was 23.
Yeah. So again, the age of the patient suggests that something like refractive lens exchange, which may have been a possibility if the patient was, say, 45, 55, or something like that, is not really present as an option. And then the next thing is looking at your measurements. I think it reminds us all, and we have in the audience people who are techs and optometrists, that did you do these manifest refractions yourself?
Yes, I did them myself.
Yeah. So so much is based on the precision and the time that is needed to take a proper refraction. So that definitely is an art that, as refractive surgeons, we definitely emphasize. But we want to also let our optometry and tech colleagues know that it is something that is very important. So when you're splitting, small little details in terms of cell axis and amount of cell, it's very important to have good, reliable measurements. That comes back to making sure the surface is really good and optimized before these measurements are looked at to make surgical decisions. And sometimes in these cases where it's very irregular corneas, it's not a clear-cut answer as to which way we should go. A question I had is, if you're looking at a 23-year-old, you looked at the PTK, which gives us corneal information, whereas the manifest would give you corneal and the whole system, the whole eye information, lens plus cornea. So you decided to look more at the cornea, is that right?
Yeah, I decided to look more at the cornea in this patient. I paid attention during the exam to the lens to see if it was perfectly clear and to see if there was any sonular weaknesses, because he had a trauma in when he was a child, and that was the cause of the keratoplasty. So the lens was perfectly clear. He didn't have any sonular weaknesses. The rest of the eye was looking perfect. So at his age, with this defect, we know that he has this graft that has a complication of being small and off-center. So we know that most of the defect is going to be in the cornea, actually. So if we do so that's a discussion that we could make between choosing a waveform-guided treatment or a topography-guided treatment, right? Doing a waveform-guided treatment, we are measuring like the whole eye aberration. But the problem in this patient is only or mainly in the cornea, a highly aberrated cornea. So that's the reason why maybe doing a topo-guided treatment that I didn't have available, but I would have done, would have give us the best result, because it would have fixed the actual problem in the eye, that it's the cornea. It would have fixed the anatomy problem that this patient has, the anatomic problem.
I think that's a good point, because the cornea has the irregularity in it, but sometimes as you know, the manifest axis does not entirely match with the topographic axis. And in these cases, the tough part is really determining the amplitude or the amount of cylinder and then the axis of cylinder. And so one thing that I sometimes use in these patients, whether it be keratoconic or scarred or graft patients, is let them select themselves the axis. And so I just direct their hand to the foreopter, and they kind of
I usually do that. I learned it. Yeah, sorry.
Go ahead, Esteban.
No, I usually do that. I learned that from you, of course. So I do that, but you know that with some patients, they don't really understand how to do it. So you have to do it yourself. And you know that the manifest refraction is actually compromised between the patient, what he sees as the best visual acuity at that moment, and all the aberrations in the eye. That's why I really think it's correct, the theory of optimizing the axis with the topography in these patients, because we are actually correcting an anatomic defect, and not something that is actually, as I said before, a compromise between so many things that we are not, we don't actually have the technology to correct at least up to now.
I agree with you. These are really interesting cases that kind of make us think quite a bit, and kind of see it. Again, I'm glad you're doing these cases so that people in the audience and myself can always tap into your experience now to see how to do some cases, because these are cases that with the topo-guided treatments that we have now available with various excimer platforms, the technology that's coming available, whether it be high definition or better red definition, OCTs, FE mapping, all this points to our ability now to treat these patients with irregular corneas and in a more kind of systematic way. So some of the principles you've illustrated go with how to approach these patients in a systematic way, because it is, you're right, it's quite a bit of gray zone in terms of what the treatment should be. Any other comments from the group? Okay, any other comments, Esteban, from your point of view in terms of what you want to impart as key concepts for the audience?
I think the key concepts are what we talked, to do a very good refraction, manifest refraction for this, mainly for the refractive cases. We don't have to be in a hurry when we're seeing those patients, because we have to invest some time with them. With these specific patients, I think I refracted him for around 20 minutes in each visit, because he wasn't really convinced with anything. So I think that's the main point. We have to be really the most precise we can with all the measurements that we do. And I think another advice would be to really understand what technology we're using to try to make the most out of it.
And how long did it take for your patient to get to that post-op refraction?
3 months.
Awesome. Well, that's another great case. Well, thank you so much. And if there's no further comments from the attendees, Esteban, thank you so much for your time. Great cases. And as I mentioned to you, this will be recorded, and once we get around to it, we'll upload that onto our YouTube channel. So thanks again, Esteban. Have a great evening, and hope to see you soon in person.
Okay. Thank you very much, Dr. Beggs. Thank you, everybody.
Okay, bye-bye.